Thank you, and it's a pleasure and honor to be part of this symposium. First, great thanks to the organizers for the invitation, and it's great to talk about a topic that is very dear to my heart, and I've been following very closely over the last 8 or 9 years. Of course, it's very difficult to talk about MERS without contrasting with COVID. But what we'll start with is looking at the historic overview of the 21st century viral outbreaks. And as you can see, we have seen multiple outbreaks of different diseases over the years. Since 2012 in September, to be exact, 21 in September 2012, we have seen the emergence of MERS-CoV in the Kingdom of Saudi Arabia, and then since then it has spread to 27 countries across the globe. If you contrast that with COVID, in over 8 years we've had close to 2,500 cases with 35% mortality. This is in contrast to what we have seen now over the last year and a half or more with COVID, where we've seen more than 200 million cases of, or 150 million cases of COVID with significant mortalities up to 5 million cases. All these diseases tend to emerge, as was very eloquently said by the previous speaker, from animal reservoir, and this is by the sort of extensive contact between animals and humans. Now, coronaviruses are not new viruses. They've been around for a long time. They first emerged in the 1960s with the very mild coronaviruses that tend to cause upper respiratory tract infection and GI infections. And then it was not till 2003 that we've had the first SARS-CoV that emerged in China. And then since then, we have seen the MERS in 2012, and of course the COVID more recently in December 2019. It is important to sort of look at the origin or the animal origin of all these coronaviruses. They seem to have a very close link to bats as the initial origin, and then there's always an intermediate host that would be sort of facilitating the spread from the animal reservoir to humans. And basically, with MERS, camels have been identified as the intermediate host that transmit the disease to humans, and this is in contrast to other coronaviruses which are linked to different other reservoir. This is contrasting the timeline of the emergence of human CoVs, the reservoirs, and the intermediate host. And if you look at the left side of the slide, these are the emerging human coronaviruses, SARS-CoV-1, the MERS-CoV, and the 2019 SARS-CoV-2. And as you can see, they have different, although they have the same origin, at least thought to be bats, the intermediate host is quite different. And this is just shows you the distribution of the cases of SARS-1 versus MERS on the left side of the slide, and then on the right side of the slide, the extensive distribution of COVID-19, which has actually spread to every single country across the globe. If you contrast that with MERS at the bottom of the left side of the slide, you can see that it emerged in KSA and some of the other Gulf countries like Qatar and Kuwait, but has actually been able to spread to travel to many other countries, up to 27 countries across the globe. This is I know it looks like it's a busy table, but it's just a general characteristic features of the SARS-CoV, MERS, and SARS-CoV-2, and basically gives you a contrast between the 3 different coronaviruses, the time when they emerged, the origin of where it came from. Both SARS-CoVs 1 and 2 have originated from China, while MERS-CoV originated in the Kingdom of Saudi Arabia. Most of them transmit through the respiratory route, aerosol, droplet, and contact. Although the relevance of contact in the SARS-CoV-2 has been debated over the last 2 years. And of course, we know that the camels are the source of MERS, but it's unclear for SARS-CoV-2, and the civet cats have been linked to the SARS-CoV-1. They use different receptors, DPP4 for the MERS-CoV, but for the SARS-CoV-1 and 2, they use the AC2 receptors. And I think what's unique is the case fatality rate, where it's extremely low in SARS-CoV-2 compared to MERS-CoV, where it is up to 30 to 40%, depending on the comorbidities associated within the host that is infected with the virus. So I guess the question that we always ask is how come COVID-19 has been able to spread so rapidly and involve so many people across the globe, and MERS has not been able to do that? I think I was able to list at least 7 or 8 reasons why COVID has spread so rapidly. The virus tropism to the human respiratory tract is different. With COVID, it involves the whole respiratory tract, and I'll show you some illustration of that. Also, the presence of the AC2 receptors in the human body is much more extensive than in DPP4. The airborne transmission which is much more efficient with COVID-19, and the consequent super spreading events that we have seen over and over again with all the coronaviruses, but it seems like with COVID, it's much more prevalent. The ability of coronaviruses to survive in the environment, and also what's unique about the COVID is that they're actually infectious prior to developing symptoms. So the 5 days before the illness start is the sort of maximum infectiousness, and that's different from what we have seen with SARS-1 and SARS and with MERS. And of course, we know that with all the coronaviruses, we tend to develop the rapid immunity, and then that immunity declines over time. We've seen that with MERS, and we've also seen it with COVID as well. And what's unique about COVID is that we have seen many variants of concern over the last year and a half, and every time we have a new variant, the R0 will actually increase, and that will lead to sort of much more rapid spread of the virus among the population. So this is an illustration of the presence of the AC2 receptors and the tropism of the virus to the respiratory tract. If you look at the right side of the screen, you can see that this is only for MERS, which is tend to be much heavier on the lower respiratory tract. But in the middle of the slide, you can see that how COVID is able to infect every single part of the respiratory tract, the upper, the middle, and the lower part of the respiratory tract, and that's why it has been so easily spread across individuals across the globe. The presence of the ACT receptors, you can see on the left side of the slide. You can see that the darker the color, the higher the concentration of the receptors, and on the right side of the slide, the darker the color, the more virus has been identified in different organs. So there is some correlation between the presence of the ACT receptors and the virus presence in the different parts of the human body, and certainly it's much more extensive in distribution within the human body, which facilitate infection and disease. The issue of airborne transmission, which was initially debated for COVID, was very clear for us in MERS-CoV, especially with a lot of the super spreading events that occurred in the Kingdom of Saudi Arabia, but also happened in Korea, where they had one traveler coming down with COVID and with MERS, and was able to transmit the disease to thousands of people within Korea. So the super spreading event is very critical for most of the coronaviruses, including SARS-1 and SARS-2 and MERS as well. And you have somebody who's coughing or sneezing or singing or talking, and that will generate aerosols and droplets, and will be able to infect people who are close to you, and also recipients at a further space from the donor. This is much more clear, showing the size of the particles. If the particles are less than 5 micrograms, they tend to sort of stay in the air for a longer period of time, and they tend to sort of spread much wider. While the larger droplets, 5 to 100 micrograms, they tend to sort of drop within 1 meter of the host, and then they stay on surfaces viable and tend to sort of transmit to others. So this is looking at the 3 coronaviruses, SARS-CoV, MERS, and SARS-CoV-2, and you can see that they have been documented in air sampling and PCR, and also air sampling and cell cultures. And at least for MERS and SARS-CoV-2, they have been demonstrated in animal models and lab or clinical studies, showing the evidence that the virus does spread by the airborne transmission. The debate that took place at the beginning of the COVID with the sort of route of transmission, is it droplet or is it airborne, and the need for sort of much more extensive respiratory protection by using the N95 has delayed the rapid response and had actually propagated the rapid spread of the disease. We do know that all the coronaviruses tend to stick on the environmental surfaces, and they tend to survive for a significant amount of time. Sometimes up to 72 hours and longer. And we also know that diseases that emerge that tend to cause mild or asymptomatic syndrome, and that can spread while asymptomatic, are much more difficult to control. This is compared to having diseases that are very severe or fatal, and they can actually be detected very early and controlled very early. Now, this is the debate that went on the role of the environment in spreading the coronaviruses. We have seen on TV very early on that millions of dollars were spent on decontaminating the streets and public transportation. Although some of the scientists say that this is probably not a very common route of transmission. So we in KSA and the region and many other countries have not really invested much in sort of fogging and spraying and disinfecting schools and streets and so on. And this is, I think, the critical part that differentiate MERS from COVID is the period of infectivity. We know that at least up to 40% of COVID patients are asymptomatic, and they can still spread the disease very efficiently. This is very close to what we have seen with MERS. Between 25 to 35% of MERS patients could be completely asymptomatic and be able to spread the virus. And this has been documented over and over again by looking at patients and also at clusters in many of the healthcare facilities within the Kingdom of Saudi Arabia. So this is the status with COVID, which is very not similar to MERS, because MERS tend to be infectious once the person is developed symptoms. But you can see here the 5 days prior to the start of the illness with COVID, that's when the person is very infectious. And then once the symptoms start, it just takes 3 to 4 days for the virus to fade away, and they're no longer infectious. And by day 8, most of the viral cultures will not grow any virus, which is unique for the COVID, and that's why it spreads so fast. Of course, depending on the severity of the illness, you'll get a higher peak of IgG antibodies, but most of these antibodies will decline over time. And the difference between the two peaks is that the decline will be a bit slower for the more severe disease. So if you have a mild disease with MERS, sometimes you don't develop any antibodies or a very minor antibody response. But with severe disease, you get a much higher peak of the IgG antibodies. And this is what I was talking about with the variants. If you look at the different variants that we have seen, they have been renamed by WHO into Alpha, Beta, Gamma, and Delta to sort of avoid linking it to countries. And then if you look at the right side of the slide, you can see how these variants have increased the R naught significantly, which means that the virus is much more transmissible and it can spread easily between patients. The clinical presentations that we have seen with COVID is actually with MERS is very similar to COVID. You know, upper respiratory tract symptoms, fever, cough, and you know, very difficult to differentiate from other viral illnesses, whether it's flu or SARS-1 or SARS-2. And of course, the more and more comorbidities you will have a higher mortality. So if you have 2 or 3 comorbidities like hypertension, diabetes, and chronic lung or liver disease or kidney disease, then you'll have a much higher mortality compared to somebody with no comorbidities. And similar to what we've seen with COVID, there's a significant number of individuals who have asymptomatic disease, and they can be the source of sort of community outbreaks and healthcare facility outbreaks. With MERS, we have seen 2 distinct forms of disease: severe illness in the immunocompromised, and usually in the primary index case. And then we have seen mild and asymptomatic disease in the young, the healthy, and mostly among healthcare workers who basically tend to spread the virus to patients and other immunocompromised individuals. This is sort of looking at the impact of MERS on the index case, and we always think that the index case is the one that has the most viral load. And it's surprising to look at the age of these index cases. You know, some of them are quite young, as young as 24 years of age. But in most of the outbreaks that we have investigated in Saudi and also in Jordan, we have seen that the initial index case usually passes away from that viral load that they have in their lungs. Again, very similar. We've seen 30% asymptomatic infection with MERS, very similar to what we have seen with COVID. And of course, the camels have been documented over and over again as an intermediate host, carrying the virus into its upper respiratory secretions as well as in its GI tract, and the virus has been isolated repeatedly from the secretions of the nasal and respiratory secretions of the camels, as well as the stool of the camels. Diagnosis, you know, similar to what we've seen with COVID, you know, PCR is the gold standard. Unfortunately, despite the fact that we've had 8 years of MERS-CoV, we have not had the significant advances that we have seen with the pandemic. I guess because of the impact of the disease, which affected only, you know, a small number of countries contrast to what we have seen in the pandemic with COVID. So there's not been a lot of investment in point of care testing, and then the serology has not been sort of very accurate in detecting cases. But there have been many serology kits that have been developed and have been used, but it has not been used extensively in investigating outbreaks. It was more for seroprevalence and epidemiology of the disease on a national level. We do know that patients with MERS who have lower viral load, lower CT value, they have a higher viral load. And then, you know, once you get above 25 CT value, you will not be able to culture the virus. And in many of the clusters that I have looked after within the kingdom, the CT value is usually less than 16 or 15. So you see a very low CT value with a very, very high viral load that tend to spread to 15, 20, 30, up to 40 individuals within one cluster. Of course, the sputum and the tracheal aspirate were the highest yield, and these are just looking at different samples and their yield of positive PCR. And this is some data from Korea, which showed that investing in having a good respiratory samples is useful. And that the sole reason is because the virus is present in the lower respiratory tract compared to COVID, which is present in the whole respiratory tract. And this is to show you how the time to negative test, it takes up to 30 days to sort of decline of the PCR positivity. We have seen that with some of the COVID cases where they persist to be positive, but they're not actually infectious. If you try to get the virus cultured, it will not be possible. And we've seen patients who are healthcare workers who have been positive by PCR for up to 6 weeks, and very similar things have been seen within COVID. Of course, infection control implications apply for both or for all the coronaviruses. Aerosol transmission tend to cause super spreading events, and we have to be very, very careful in ensuring that there is early detection, not missing any asymptomatic cases early enough, and then being able to sort of convince the healthcare workers to continuously wear respiratory protection to prevent any unsuspected outbreaks. So what we've learned about the diagnostics in MERS is that PCR is the way to go. We have not been able to succeed in finding rapid point of care testing, and serology was used, but not extensively. Unfortunately, because again, MERS did not cause a massive global outbreak and not a pandemic similar to COVID, we have not moved much into therapeutics and vaccine. And we've seen that with COVID, we were able to develop multiple vaccines within 9 to 11 months. This is, of course, not the case for MERS. This is just published a few days ago in Lancet Microbes, looking at the Chaddock's MERS vaccine in phase 1B trial. So we still have a long way after 8 years or 10 years have passed since MERS was initially emerged. So you can see how the impact of pandemic and the global support and sort of solidarity and working together and sort of making the vaccines and therapeutics and even diagnostics much more efficient. Of course, with MERS, we still have a lot of knowledge gaps. We don't know where the virus origin is from. We have been able to document part of the virus from bat, but we have not been able to isolate the full MERS virus from bats so far. And then, of course, there's a lot of knowledge gaps in the epidemiology and transmission, also the management, infection control, which we have actually gleaned much more information with the COVID because of the extensive global research agenda. And then when it comes to therapeutics and vaccine, we have not seen a lot of improvement in that with MERS. And over the last few years, since COVID has taken over, testing for MERS is not being done as extensively as it used to be in the past. So we're not sure if MERS is still happening in the background in KSA as well as COVID together. So in conclusion, MERS transmission, similar to all the coronaviruses, can sort of lead to sporadic community cases, and then it can actually have outbreaks within healthcare facilities and within the household. There's significant amount of asymptomatic disease that spreads. Diagnosis for MERS still continues to rely on the RT-PCR, and then we need to have lower respiratory tract samples because that's where the receptors and the virus is most. And then the biggest challenge is to identify MERS-CoV patients early because the symptoms they present with are very similar to other influenza and other respiratory viruses. Need for improvement in infection control in healthcare facilities. I think that helped us in managing COVID because people have been trained over and over again to deal with MERS. So reinforcing it for COVID was much easier than countries that have not dealt with MERS or SARS-CoV-1. Healthcare workers continue to be at risk, and as you probably heard, we've lost significant amount of healthcare workers on a global level with COVID. We still don't have any point of care testing, and we still don't have a vaccine. And I hope the work continues to develop the vaccines for the future. So I'll stop here, and I'll be happy to answer any question.
Cool. Many thanks for the talk, Professor Ziad. We have time for a couple of questions, which I'll read out to you that have been submitted here. So one question, I suppose, in terms of management of MERS-CoV, do you think you would apply remdesivir, corticosteroids, and other treatments which have been established now for COVID?
No, I think corticosteroid has been tried initially with MERS-CoV and have been proven based on some meta-analytic data of small studies that have been done in KSA that they actually make the prognosis of MERS much worse. So corticosteroid is not being encouraged to be used for MERS, and surprisingly, it is very effective in COVID. And then the remdesivir was not used at that time for MERS. But, we have tried interferon, and it did not seem to do much on its own. And then with combination of different other antivirals, there was some mild effect, but nothing significant that like we've seen with COVID.
Okay, thank you. Interesting. How do you feel? What is the potential for co-infection with MERS-CoV and COVID?
That's a very good question. And I was searching yesterday on some of that data, and there was one report from the eastern province of the Kingdom of Saudi Arabia where they looked for both viruses in the ICU, and they found at least 10 patients who've had over the last year who've had both MERS and COVID at the same time. And obviously, you would expect that they would have a much higher mortality, which was the case, and the patients were had much more comorbidities. So having both viruses at the same time seems to be possible because it's been documented and reported, and they definitely lead to sort of worse prognosis than having one virus alone.
Okay, great. I think we have time for one further question, if you don't mind. The question that we have here is what you see as the potential for use of point-of-care testing for MERS-CoV with mass screening and potential for home testing in the way that it's done for COVID now?
Well, I think it would have made a huge difference. I was lobbying for, point-of-care testing for 6 years when I was focusing on MERS, and nobody listened to me. So I think when you talk to companies, they say it is not worth the investment because the disease was very limited. But of course, it's much worse now with the COVID affecting every single country on the globe. So definitely, I think it would make a huge difference in rapid diagnosis and picking up cases quickly.
Cool, great. Thank you. Thank you very much for the great presentation, Prof. Ziad. And we're very privileged to have you here talking to us today. And now I'm going to hand back over to Prof. Gavin Smith, who will introduce the next speaker.